Hi, my name is Heidi Combs. I'm a psychiatrist, and I'm here from the University of Washington in Seattle, Washington, at the annual American College of Physicians meeting. Very excited I get to talk today about anxiety and depression in primary care. This is near and dear to my heart because most of patients with anxiety and depression are actually not treated by psychiatrists, they're treated by primary care physicians. So one of the goals for my talk is to help primary care physicians identify how patients with anxiety or depression are going to show up when they come to their practice. The majority of patients with anxiety and depression do not come in saying, I'm anxious, I'm depressed. What they come in complaining about are very nonspecific symptoms which you have in your practice many times a day. I'm not sleeping well, my energy is poor, I have pain. That's what 20 to 50% of your other patients are presenting with. So it's a common way of patients presenting when they come to your clinic. So how do you sort out, is this depression, is this anxiety, or is this a medical condition of some sort? So the first thing to do, I think, is being aware of how common both of these disorder groups are, both anxiety and depression in primary care. Up to 20% of your patients are going to have anxiety and depression. So you should be thinking about that when you're seeing patients. The second thing is understanding that there are medical conditions that can mimic or exacerbate anxiety and depression. Understanding if someone has had a stroke, for example, they're at increased risk for depression. So understanding those common medical conditions that can be related to anxiety and depression are important for a primary care physician. I think probably the single most important thing, though, is to have these things on your radar. So when a patient comes in with nonspecific physical complaints, early on you should be thinking about screening for depression and anxiety. Most of you feel pretty comfortable screening for depression, I think. I think the most important thing is, one, have a systematic way of doing so. Either have specific screening questions that you ask, like how is your mood, do you feel low, have you been feeling disconnected from your life recently, or using formal screening tools like PHQ-2, PHQ-9 for depression. For anxiety, I have several common screening questions that I use. For panic, I say, do you ever have a panic attack? I know it seems like I'm cheating, but the truth is most people actually know what those are, even though they actually don't realize the symptoms they're having are really panic. They think it has to be something worse than that. So for generalized anxiety, do you consider yourself a worrywart? People with anxiety that have generalized anxiety will know that they worry a lot. How do you do when you're in a situation where you feel like you can be scrutinized by others? Do you have intense anxiety? It's a screening question for social anxiety. And for OCD, do you have intense, intrusive thoughts that come into your head that you can't get out, or things you need to do over and over, count, check, those kind of things? And then finally, for post-traumatic stress disorder, the common screening tool I ask is, what's the worst trauma that's ever happened to you? If someone says, I didn't get into AOA when I was a medical student, probably not PTSD. If someone says, the sexual assault, well, no, maybe it was when I was beaten. Like, when people have that kind of history, you really need to be screening for PTSD. So there's lots of screening tools also that you can use for anxiety, like the GAD-2, GAD-7, there's a PHQ for panic, for example. So just like with depression, you have a screening questions, or you can use screening tools. Anxiety, there are screening questions. You can also use screening tools. Once you detect that someone has anxiety and depression, the most important thing is be aggressive in your treatment. The two general paths of treatment for people with anxiety and depression are psychopharmacology or psychotherapy. Really effective. Both of them are really effective. Really, it's going to depend in part on what the patient is willing to accept. Some patients do not want to do psychotherapy. Other patients do not want to take a pill. So really identifying what is the best match for that patient, and then deciding. There's lots of different options for psychotherapy for patients. So that's an option for people. People often think of CBT, for example, as a standard of care. Then for psychopharmacology, there's all kinds of antidepressants that are very effective that you can use, and that would be a first-line agent for both depression and anxiety. And I think some people also want to do combination therapy, and that again depends on the patient's acceptance of that. If you have a mild to moderate depression or anxiety, psychotherapy or psychopharmacology should be enough. If they have more moderate to severe, they may actually need treatment both from psychotherapy and psychopharmacology. So keeping both of those things in mind if you have a more severe patient may be important. Another thing I wanted to mention, I don't want you to leave this conference without thinking about insomnia. Insomnia people often associate with, well, if you have depression, insomnia or sleep disturbance can be a symptom of that. If you have the anxiety, sleep disturbance can be a symptom of that. That is absolutely true. However, insomnia or sleep disturbance is an independent risk factor for developing anxiety and depression further down the road. There's this bidirectional relationship between sleep disturbance and anxiety and depression. So keep an eye out for insomnia. Make sure you aggressively treat insomnia because it may help reduce the risk of someone developing anxiety and depression, or if they have a depression or anxiety, treating their insomnia will actually help those symptoms. The best treatment for sleep disturbance, cognitive behavioral therapy. That is the best treatment, not a pill. So CBTI, cognitive behavior therapy for insomnia, is the standard of care for treating people with insomnia. There's also pharmacologic options. All of those have problems. They can be helpful, but there are also issues associated with them. So try, if you can, to do CBT first. So final thoughts, to wrap all this up, is anxiety and depression are common, and 80 to 90% of patients with anxiety and depression get all of their treatment from you, not from a psychiatrist. There's very effective screening tools you can use to detect these disorders. There's really good options for treatment, both medications and psychopharmacology, but they only work if you actually identify it and help the patients understand what they're experiencing and get good treatment. Thank you.